rest combined with movement and exercise is the best way to attack cancer-related fatigue. So our job as a physical therapist is not done the day somebody finishes treatment. We also have to walk into survivorship with them. And if the patients are not our caseload anymore, we're not going to be able to help them with the pain that they're experiencing. And then it's not just for healthy people. All right. And it shouldn't just be for weak people, like, oh, you're not sick, so you don't need to go. Or you're not sick yet, so we'll send you later. When I teach physical therapists, everything you're going to use as a skill set is therapeutic exercise, manual therapy, neuromuscular reeducation. These are all things that we all do. With oncology, you're just applying those skills in a different way, certainly in a different timeline. So there's certainly differences in cancer rehab than musculoskeletal rehab. Healthy cancer patients are a possibility. Healthy cancer patients are better for the community. They recover more quickly.
Welcome to Oncology Revolution, where science meets care to transform the cancer journey. We explore evidence-based strategies to enhance quality of life, promote longevity, and empower patients and professionals to thrive beyond cancer.
Welcome, everyone, to another episode of the Oncology Revolution Podcast. Today, I will be the host, and let me start by introducing myself. My name is Raquel Maris. I'm an occupational therapist with an executive MBA and working as a project coordinator at the European School of Lifestyle Oncology. Here with me, we have a very special guest who has been inspiring professionals and patients around the world. Leslie Waltke is a physical therapist with exceptional clinical expertise in oncology and one of the world's most respected educators in cancer rehabilitation. She is known not only for her deep knowledge, but also for her ability to connect with people, whether it's in a lecture hall or through her inspiring YouTube channel, The Recovery Room. Leslie, welcome to Oncology Revolution. It's a real honor to have you.
Thank you, Raquel. Glad to be here, and good morning and good afternoon to everyone.
Before we dive in, I would love to hear a bit about what brought you into oncology rehabilitation. What inspired you to dedicate your career to this field?
Well, you know how we all kind of see the world through the eyes of our own profession. So I have been a physical therapist, my goodness, almost for 40 years. And I was treating shoulders and knees and backs and hips like most physical therapists do. And then a family member was diagnosed with cancer. And we were both in our 20s. And it opened my eyes to so much that I wasn't aware of, right? And we think of surgery, chemotherapy, and radiation when we think of cancer. But then living with cancer in my home, it was pain, fatigue, weakness, fear, insecurity, inability to go to school, to work, to drive. So again, looking at it from a physical therapist perspective, I'm like, it was such an unmet need, especially back in the 1990s. So it really kind of shifted my thinking and my drive. And I started looking into it, and it just became a very passionate point for me in my life. And I have lived in this space ever since, and I continue to do it. I've lost many more people to cancer in my family in my life. But to be able to be a professional, and everybody knows this, to be able to help somebody with cancer live better, live longer, smile more, walk better, live better, that is the best way, in my opinion, to get back at cancer for what it takes from all of us. So that's kind of my journey in a nutshell. I could talk for hours.
Thank you. Thank you for sharing. Many people are still surprised to learn that physiotherapy plays a crucial role across the entire cancer continuum, from rehabilitation to active treatment, recovery, and long-term survivorship. Can you walk us through how a physiotherapist contributes at each stage, please?
Sure. So again, to talk about, again, when we think of cancer, we think of radiology, pathology, surgical oncology, medical oncology, radiation oncology. But when you introduce those pieces into the human body, you end up with a side effect profile that at this point is well established, well understood, but undermanaged. So from surgery alone, you potentially may have, again, depending on the type of surgery, where it is in the body, but pain, weakness, limited mobility, scarring, difficulty swallowing, difficulty walking, difficulty with range of motion and tissue tightness. And then risk for infection, risk for lymphedema. And then from your chemotherapy medications or your systemic therapies, you're going to have fatigue, weakness, again, neuropathies, chemically mediated pain, loss of function. I mean, the list just goes on and on and on. And then from radiation oncology, again, you're going to have pain, fatigue, weakness, scarring and fibrosis, long-term tissue tightness. And all of those things directly contribute to mortality and to morbidity. Overall outcomes change. Treatment compliance is impacted by those things. And then that certainly is going to roll into the person's life, their ability to work, their ability to function, their ability to be a family member. So with the introduction to with a physical therapist, occupational therapist, again, that's what we do, right? We live in the world of musculoskeletal, cardiopulmonary, integumentary, and functional deficits. So it's a very simple, but kind of outside of the box thinking for many people that are just solely focused on the cancer cell. So it's a fantastic adjunct. And as you mentioned, we really want to, since deficits start immediately, we want to begin immediately. So again, depending on the type of cancer, because different cancers have different protocols of what do we start with first, whether it's chemo-rads or neoadjuvant chemotherapy or surgery. But peri-diagnosis, we want to have a physio or an occupational therapist step in onto the treatment plan. So it's not just a recommendation, it's actually a part of the care plan, which is a big difference. So it's not just a need to, or like a nice to, it is a need to. So peri-diagnosis is really the time to intervene. If somebody is going to start with neoadjuvant chemotherapy, we start with a simple walking program, a simple resistive exercise program, again, based on who is the patient. Are they 20 years old? Are they 90 years old? Are they fit? Are they unfit? Are they diabetic? Do they have a rotator cuff tear? Are they experiencing neuropathy? So a qualified rehab therapist can look at that individual patient and create an individual exercise prescription based on their needs. And then what equipment do they have? Do they live in the north? Do they live in the south? Is it too hot? Is it too cold? What do they have at home? What do they have access to in the community? What is their exercise literacy? Some people have no idea what to do, and other people are like, oh, just tell me what to do and I'll go. So that's kind of the rule during chemotherapy, is creating a prescription and then helping that patient progress and regress what they do depending on how they feel. Some days they feel great. Some days they don't feel great. As things progress, things can get more difficult. So keeping people moving is kind of the key during chemotherapy. Then post-surgically, again, the range of normal post-surgery is huge. Some people walk out of surgery, they're like, I'm fine. Fantastic. Let's look at you, make sure you are, because people often will miss deficits that they don't know that they have. So it's nice to have a professional look at them, actually do a physical exam and say, yes, you are fine. And then there are people that are not fine, and some people that are train wrecks. So again, having a person, a professional on the team that's specifically dedicated to pain, weakness, fatigue, all of those things that physicians and nurses hear about, but don't have time or the skill set to address. And then with radiation, our role is kind of twofold. First, the acute phase where the person's actually getting radiation, whether it's days or weeks. They may be impacted by fatigue. They may be impacted by skin reaction, changing what they can and can't do. So again, a physical therapist can help, again, create an exercise prescription specifically for that phase. If we need to adapt activity or exercise based on this now hurts when I do this, I can't sit on a bicycle seat, or I can't lift my arm over my head, we can adapt to that. And then very importantly is post-radiation, when people over the next usually a year to a year and a half, where the soft tissues start to thicken and tighten and the fibrosis sets in. So our job as a physical therapist is not done the day somebody finishes treatment. We also have to walk into survivorship with them because a lot of the scar tissue takes, a lot of the fibrosis takes a good year and a year and a half to develop. And if the patients are not our caseload anymore, we're not going to be able to help them with the pain that they're experiencing. Many, many, many studies show that upwards of 30 to 40% of cancer survivors are still complaining of pain years into survivorship. And much of that is most likely musculoskeletal weakness issues, integumentary issues that a good PT or OT could get rid of in a week or two. So our job in survivorship is not finished. We also have to encourage people to continue to exercise. It's not easy in a crazy busy world that we live in to maintain an exercise prescription. But we know that exercise prescriptions in survivorship actually improve morbidity and mortality. So putting somebody through surgery, chemo, and radiation to cure their cancer and then not give them the fourth treatment of exercise is a little insane. And again, most people with cancer still die of heart disease. And one of the best things for heart disease, again, is exercise. So it absolutely should be a piece of survivorship. And again, along with long-term neuropathies, cognitive impairment, again, depending on the type of cancer, pelvic floor, sexual health, swallowing, and then just integrating back to regular life again, dealing with the potential risk for lymphedema, and those long-term late side effects like cardiopulmonary health and in soft tissue and scar tissue, again, are something that are really kind of in the scope of a physical therapist that really truly is seeing somebody from diagnosis all the way through the continuum into survivorship.
Sure, that's huge. And we still yet hear so many myths about exercise during cancer treatments, like the belief that people undergoing chemo should just rest. And that is what is your perspective on that?
And rest is always important. Rest is a tool, right? The body needs rest. However, we know factually that if rest is not coupled with exercise and movement, it is going to cause decline. All right. So rest alone is not helpful. Rest combined with movement and exercise is the best way to attack cancer-related fatigue. So we know that, most chemotherapy drugs can affect cardiopulmonary function. Most drugs can cause sarcopenia, which is loss of skeletal muscle mass. And that is what contributes to that physical loss that can contribute to fatigue. So by just continually, gradually moving people, we can eliminate a lot of that. Some of the other myths that we run into is it's not just for breast cancer. Okay. Everybody, I mean, certainly there is a bias towards referring people with breast cancer to physical therapy. However, remember the deficits that we're treating. We're not treating cancer. We're treating the side effects of these treatments. So anybody that's going to be exposed to surgery, chemotherapy, and radiation should get a rehab consult. So not for to our folks with leukemias and lymphomas and colon, breast, or colon, lung, prostate, melanomas, multiple myeloma, everything should get, anybody that's exposed to treatment should get a physical therapist. And then it's not just for healthy people. All right. And it shouldn't just be for weak people, like, oh, you're not sick, so you don't need to go. Or you're not sick yet, so we'll send you later. So even if somebody is happy and healthy during their chemotherapy, doesn't necessarily mean they're not going to have problems in the future. They are still going to be exposed to toxicities and neuropathies and cognitive impairment where exercise can help. And then again, I think another big deficit we see is I'm too sick to exercise. I'm too weak to exercise, which itself is kind of it's a bad connection. So when you hear the words, I'm too weak for exercise or I'm too sick for exercise, that's not a contraindication. That's an indication. So the sicker people are, the weaker people are, the less they know, the less they can do, the more they need the assistance of a professional on their team that can address those things. So we meet people where they are. So if you can't stand up, that's what we're going to work on. If you can walk 3 miles, we're going to help you to walk 4. So it's very individualized. So I think no matter what the patient looks like, what their skill set is, we really need to make sure that everybody is getting in to see physical therapy. I think another thing is we want to just wait until later, because they're so busy. That's another. I mean, and again, visit burden is a thing. People are overwhelmed. It's a lot. So like, oh, but it's they're so busy right now. However, we first of all, most physios across the planet will tell you that patients are so happy when they come in. Our cancellation no-show rates are usually really low because people are so happy with what we teach them and what they can learn very quickly, how to take care of themselves, how to stay stronger, how to stay healthier, how to stay pain-free. So they can tolerate all those extra visits, both physically and psychologically. They have tools they can use to make themselves feel better. So patients do not complain about having to go. And I think, too, a lot of physicians and providers believe that if you go to physical therapy, you have to go twice a week for 10 weeks or something like that. And it's not an exercise class. It is one-on-one care. So if somebody they're a train wreck and they can't get out of a chair, they need that, they're going to get that. But if somebody comes in and they don't need that, listen, I don't have any pain. I know exactly what to do. Just tell me what my prescription looks like, and I have all the equipment at home. Then we may see them do this, this, and this, and this, and come back in 3 months. So people aren't slotted in to like, you have to do this twice a week for 10 weeks or so. So it's very individual. And then finally, again, certainly here in the United States, where our payment model is very different from other countries, people just like, oh, physical therapy is too expensive. And I really have to laugh at that one because oncology is very expensive. Cancer treatment is very expensive here in the US. And by the time people are in surgery, chemotherapy, and radiation, their copays and deductibles are typically completely eliminated. So most of the time, physical therapy is minimal to no cost for people. So it's not really an added burden financially to most patients. And if it is, we have that discussion, right? What can you afford from a financial perspective, and what can you afford from a time perspective? Maybe you're driving an hour. Maybe you have to work 20 hours a day. So it's an open discussion that we have with every patient to find out what is going to be best for them, and when is it going to be best for them, and how is it going to be best for them.
Course, everything should be personalized,
Yeah.
and each
Yep.
patient it's itself. So
Yep.
that's a powerful message, and thank you for clarifying those myths. Could you share a little bit about the difference that you see when you engage with patients early on in a prehabilitation phase?
Yeah. So, and I like to compare this to, so if Mr. Smith has a stroke, okay, and Mr. Smith he's scared, he's in the hospital, his family is completely freaked out, he has multiple tests, he's under a lot of strain. So the physical therapist recognizes this, the physician recognizes this, walks into his room and says, you know what, I know you can't walk right now, and I know you can't dress yourself, but you're under a lot of stress right now and strain, and you're very busy. So I'll come back in 3 months. We would never do that to somebody who's had a stroke or a car accident or, a significant disease. But we're doing that with patients with cancer all the time. And it's really unfortunate because, again, the research is very clear that treatment causes deficits. The research is also very clear that early intervention and early mobilization with rehabilitation minimizes and can eliminate some of those side effects from happening. So we can eliminate, minimize, or delay a lot of the onset of many of these dysfunctions that people have. So it does two things. Number one, it certainly decreases symptom burden. Okay. And again, we know that it increases treatment compliance, which is huge. It decreases the amount of medications, including opioids, that people need. So that's very, very important. Another thing it really does is it sets the mindset of the patient very differently. When you walk into a multidisciplinary clinic, when the patient's just getting this news, and you can say, hi, I'm sorry, I'm your physical therapist. I'm sorry this is happening to you. I'm sorry you've got a tough year coming up, but I'm going to be by your side at every step. Every time, I'm going to make sure you're as pain-free as possible. I'm going to make sure you're strong and healthy, getting up and down the stairs, in and out of the car, staying at work, staying at whatever you do. We're going to help you be you during this process, keep you as strong and as healthy as possible. And then when it's finished, get you back to normal as quickly as possible. So that absolutely sets the mindset for somebody going through treatment. They're going to be certainly more positive, more resilient, less symptomatic. They're going to go to the hospital less often. They're going to go to the emergency department less often. They're going to fall less often. They're going to go to work more, stay on their chemotherapy better. So early intervention in oncology is no different than orthopedics, neurology, and cardiology. We do it there. We need to do it in oncology as well. And again, the research is absolutely there.
For sure. And it's such an amazing, strong evidence that we already have about exercise in oncology care. Even this month came out an amazing article on the New England Journal of Medicine about exercise being more effective than some medicine that is just improving outcomes of cancer survivors. And this is amazing.
Yeah. So I love this for many reasons. Number one, we've had data for literally 10 to 15 years, overwhelming data that exercise just is so good for people during treatment, after treatment, to decrease morbidity and literally mortality. Much of that has been observational. So what I love about this study is, number one, that it is a randomly controlled trial, and that's incredible, right? But what I love most about this study is that the buzz that it's getting. I mean, everybody is talking about it. And we should have been talking about this 15 years ago because we already knew it was working and it has been working. But I love, love, love the attention that it's getting. And again, I'm hoping that that translates into clinical care, because research to bench to bedside, as we know, can be a big lost in transition thing. So I really hope that the transition is there. Another thing I really want to point out to my professional colleagues is that recommending exercise or just telling somebody to exercise is incredibly important. We know from the rehab side that if a physician or nurse just mentions the word exercise, the patient is more likely to be compliant with us. Like, oh, if the doctor said it, it must be important, right? So that's incredibly to talk about it. But just telling somebody to exercise is grossly, grossly ineffective. And it can take, so we want physicians to mention it, but still refer people to a physical therapist to make sure that they're getting the individualized instruction that they really, really need. And then a second point I really want to kind of hit home is that there is a difference between rehab and exercise. So exercise is a tool that physical therapists and occupational therapists use in their treatment plan to make somebody better. But exercise alone is not physical therapy. So I want to make sure that people know that just sending somebody to an exercise class doesn't necessarily always fix their problems. So exercise classes are good. Community exercise is phenomenal. However, everybody that goes to one of those classes or is referred to exercise should see a physical therapist first. So example, let's go back to Mr. Smith. So Mr. Smith that had the stroke, okay? So he okay, let's put Mr. Smith through an exercise program. So we strap him to an exercise bike, we exercise him for 6 weeks, we're done, and now we remeasure all of his anthropometric data, all right? And you know what? Everything's better. The exercise has helped him phenomenally with blood markers, cardiac markers, everything's great, right? However, Mr. Smith still can't walk. He still can't dress himself. He still has cognitive impairments. He still has communication issues, all right? So because he hasn't been seeing a rehab therapist. So that's really the difference between exercise and rehab. So I want to make sure that we're not solely focused on exercise, because it isn't. Everybody should be doing it. There's no question. But I don't want lost in that transition of making sure that people are seeing a rehab therapist, because again, an exercise program is not necessarily, a walking program is not going to fix cognitive deficits that impair function. It's not going to help. A stationary bicycle program is not necessarily going to help somebody get up and down the stairs more safely. And it certainly isn't going to help radiation fibrosis of the chest wall that's causing pain. So, again, it's important that everybody gets a physical therapy consult, so that person can help manage their home and community exercise, which again is incredibly important. So, the research on exercise has certainly shows that number one, it's safe during chemotherapy and it's safe during radiation. Not only is it safe, that it's feasible, even people that are really, really sick, and low blood counts. It is, again, safe and feasible, and then it's beneficial. So the data is certainly there. Exercise decreases risk of lymphedema. It decreases risk of cardiotoxicity. It decreases risk of cognitive impairment. There is now some data that show that early intervention with exercise can actually reduce the amount of neuropathy that people feel from our chemotherapy drugs. And certainly, even if we can't reduce the amount of sensory dysfunction somebody has, we can certainly help them walk better, walk safer, get up and down the stairs safer, in and out of the car, not fall as often. So the data surrounding exercise is just literally overwhelming in its positivity. And it is feasible with people with multiple myeloma that have all these bone issues and bone metastasis and stage 4 disease. So it is doable. I am blessed to, one of the wonderful things I get to do in my career is I help run a triathlon training program for women cancer survivors, called Team Phoenix. And I live about 145 kilometers north of Chicago, so I'm kind of like right on the Great Lakes here in the middle of the U.S. And so we train, so we go from surgery, chemotherapy, radiation to swim, bike, and run. So my point with this is that yes, you can take, and many of our people have stage 0, stage 1, stage 2, stage 3 disease. But I will tell you that every single year we have people cross that triathlon finish line that have stage 4 cancer. So bone mets, liver mets, brain mets, lung mets, we've had it all. So the sicker somebody gets, the more disease burden they have, the more important it is for a physical therapist to be involved in their treatment plan, because it is so incredibly helpful. But again, just telling somebody to exercise, the research also says that for somebody to be successful and compliant long term, not just like, oh, I'm in cancer treatment now, so I'll exercise, and then I'm going to quit. For long-term compliance, we want people to be educated in how to exercise, right? Like, when do I push? When do I pull back? What kind of shoes am I supposed to use? Where are safe places in my community to walk when it's cold? Or where are safe places to go swimming? Or what are some great biking places that are off-road? People need to know their community. People need to know the skill of how to exercise. Like, how do I get my bike in my car? How do I put some food in my car, so when I'm done exercising, I don't get really hungry and run off and get some fast food somewhere? So the skill set of exercising, what is safe to do from a strengthening perspective, and what does my body like and what doesn't it like? I found out that I love to swim. I found out that I hate to swim. I found out that I love to bike. I really hate to bike. And then also important with exercise is building community. People are going to be more effective when they have other people either as accountability partners, or exercise buddies. So our Team Phoenix group has a Facebook page, and now literally you'll see every single day, hey, for those of you who live in this community, we're going to meet at this spot at 6 a.m. and go for a bike ride, or we're going to go for a walk, or we're going to meet here and do a little swim. People, that keeps people engaged and encountered. It's also a place where people go and they're like, I don't have to explain my scars here, because I have a community of other cancer survivors. And I can also say, hey, I'm just not having a good day. I'm just going to take the day off. And people are flooded with support. Like, hey, good for you. You do you. So support and skill set are really important in long-term, compliance with an exercise program. So exercise sounds easy, and it is easy. It's free. Exercise is free, right? You just take a walk. But it can also be incredibly complex and very personal. So again, it does really require the assistance of a professional, maybe just a little bit and maybe a lot. Like some cancers need a little bit of intervention, some need the full inclusive package. Same with the musculoskeletal system, cardiopulmonary system, integumentary system, and functional deficits. Some people need a little bit of help, some people need a lot. And like the oncology treatments, we can give people the full dose or the minimal dose, depending on what they need. So again, it's very, very individualized.
Yeah, for sure. And the importance of those initiatives that you are mentioning and the creating the communities, it really helps. And
Yeah.
I feel like there should be so much more, and still feel that there is the urgent need to train more professionals also.
Yeah.
One of the challenges that we see here in Portugal, and maybe you see there in the US, is that we often see that there is a limited number of professionals trained in oncology, physiotherapy, and other areas also. And what is your perspective on that?
We know it's a problem, and we know it's going to become a bigger problem. We have a larger and older population, which means more cancer cases. We know we have an aging oncology professional problem where a lot of our people are retiring. And the new people coming in, the volume just isn't there to match. So we have a significant care gap. Um, and so, from my perspective as a physical therapist, we certainly see people coming out of school that are very bright, very eager, well trained, but most schools don't spend a lot of time on cancer, which is unfortunate because it's the number 2 killer in the United States and across the world. And it is so impactful to people and their communities and families. So it is an issue. And I think with the pandemic really changed the world as far as we all had video capability, but now it's on steroids, and we can communicate with people across the globe in literally a second or two. So creating more initiatives and education opportunities for people, like this fantastic podcast, to just get the word out, right? Because when we understand, I'm hoping a bunch of physios will call now, or a bunch of professionals to say, how can we get these people trained? So communication is key. Because there is a deficit. And again, I will tell when I teach physical therapists, I teach them, listen, I'm not going to teach you anything you don't already know, right? Everything you're going to use as a skill set is therapeutic exercise, manual therapy, neuromuscular reeducation. These are all things that we all do. I don't care if you live in Africa, Asia, Europe, or North America, South America. You know what those words are if you're a physio. So, but again, with oncology, you're just applying those skills in a different way, certainly in a different timeline. So there's certainly differences in cancer rehab than musculoskeletal rehab. But it's not complicated. It doesn't take a lot of time of, okay, here's the things that you do, here's what you're looking for. And then from the other deficit I think we have is oncologists are now, again, more patients, less staff. The stress level is going up, the volumes are going up. So their time is crunched even more than it has been. So, and now we're saying, oh, now you got to talk about exercise. So what I love to do when I talk with physicians and people on the oncology side, so nurses, nurse practitioners, genetic counselors, the whole group of multidisciplinary professionals, is say here, we want our job, you as an occupational therapist know this, it's our job to make their job easier. I don't want to make my oncologist job any harder than it already is. I don't say, you got to do this, you got to give them this form, no. My job is to make your job easier. So giving physicians the tools to say, here's how you refer, when you refer, how to write the order. And again, this is going to differ greatly geographically and just from institution to institution. Who calls the patient and gets them set up? That's individual. But when to do that, how to say it, how to script it. Because we don't want if the physician says, oh, maybe this physical therapy thing might kind of be good for you, and then it goes on to the next subject, they're probably not going to call. But if, we have physicians here that literally say to the patient, your cancer rehab consult is no less optional than your radiation oncology consult. You're doing it. It's a part. Like if you have a knee replacement, you go to physical therapy. If you have a stroke, you go to physical therapy. It needs to be in the lexicon and the thinking of our physicians and referring sources that you have cancer, you go to physical therapy. But again, they're not taught about physical therapy in med school, or very little about rehab, much less cancer rehab. So I will always tell my therapist, if your physicians don't know what cancer rehab is, it's not their problem, it's your problem. You're the one who's responsible for teaching and teaching so they can understand. And again, they're so focused on, like, I'm a radiation oncologist, this is what I do. I'm a medical oncologist, this is what I do. I'm a surgeon, I do this. And then so they think, well, they don't, my patients don't need physical therapy. All right. But hello, they're going to have all these things coming up, and this whole treatment plan is months and years. So we've got to get them to think more comprehensively. Like, maybe your patient doesn't need us now, but you still need to get them to us now because they're going to start chemotherapy in 4 weeks and they need to be on a walking program now, even though they just had their tonsils removed. They still need to start now. So getting them to understand, like, even though your intervention isn't impacting the person, the next one will. Therefore, they have to be in the pipeline now. So I think the education will always be a massive piece of cancer care. It always should be. We always are learning. We're always pushing the boundaries, always finding better ways. But we certainly are looking at an uphill climb at this point in regards to educating more people in what cancer rehab is, who should do it, how to do it, when to do it. But the pieces are there. We just got to keep pushing the flywheel. We're pushing the ball uphill all the time at this point. But the pieces are there, and our patients are absolutely worth it.
Yeah, I really like the idea that communication is key, and it is our mission to get the word out there.
Yeah.
So let's hope this podcast gets to the ears of a lot of physicians and physiotherapists, to get them interested in this field. And Leslie, before we close, what's one message you would want our audience to take away?
Cancer rehab is evidence-based, reimbursed here in the United States, medical care, right? It's not a nice to, it's a need to, that improves outcomes in quality of life. It improves outcomes in morbidity, and it improves outcomes in mortality. So it absolutely needs to be a part of the care plan for every single patient that hears the words, you have cancer, regardless of age, regardless of type of cancer, regardless of gender, regardless of performance status. Everyone should get a physical therapy consult with a diagnosis of cancer. And again, it's just good for the patient, and it's also healthy for our health systems. Healthy cancer patients are a possibility. Healthy cancer patients are less expensive. Healthy cancer patients are better for the community. They recover more quickly. So it's just a win-win for the patient, and it's a win-win for the professional side. They call the physician less. Again, they use less opioids. They just are happier and healthier, and it's better for everybody involved. So again, I can't encourage people enough to get their physical therapist involved with their cancer patients, from peri-diagnosis all the way through into survivorship or end of life or hospice care. Wherever the patient goes, we should be following them.
For sure. That's such a beautiful takeaway. Thank you for everything you've shared today, and thank you for your energy, your heart, and everything you bring to the field. And for our listeners, for those who want to learn more, I highly recommend checking out Leslie's YouTube channel, The Recovery Room, for evidence-based information about cancer and recovery, all presented with her signature warmth and humor. Leslie, it's been a true pleasure having you on the Oncology Revolution. Thank you.
Thank you, Raquel, and thank you, the Oncology Revolution Podcast. Glad to be here. Bye, everyone.
Bye.